I actually, we have circulated the link to other universities as well, particularly a non-medical profession, and I think we can see many of our friends here.
Yes, I'm looking at the list. Yeah, Nojahan is here from Amelia Afzan from UPM.
Yeah.
Hi, Jahan.
Yeah.
Hi, Prof. Selamat Raya.
Selamat Raya.
Right, I think now it's 2:30. I think people will come on board as we go along, and we shall honor those who have been punctual here so that we can get on to save some time.
Yes.
And right, thank you everybody for coming. Before we start, just for those not in UKM medical faculty, just to say one or two words about how I do it session. Hi, Prof. Zah. How I do it session is a so-called monthly sharing platform for our medical faculty or UKM to share teaching learning methods. It can be digital, non-digital in any way, any innovation that our lecturer think that's worth sharing, and we'll invite them to come and share. So this time around we have Prof. Zah, and we have a prominent person. I guess it's a request from outside faculty of medicine UKM. So we have opened up the invitation to many, and it's a free session. So far all presented are all from UKM medical faculty, right? So we'll see how we can grow. The size getting bigger, we may want to grow to inter-university. We'll see how it goes. Yeah, okay. So today we have a privilege to talk about bedside teaching, and we have invited Prof. Zah. Little words about Prof. Zah. I think all of us know Prof. Zah quite well. Prof. Zaleha, and she's our former dean in the medical faculty UKM, and she holds many important positions, but suffice to say she's senior consultant ONG and heads the health technology innovation technology in our faculty. And he also chaired subspecialty subcommittee for ONG at the moment. And so he has been in the GIPP group, Jawatan Kuasa Inovasi
Pendidikan Perubatan.
Pendidikan Perubatan. Thank you, Prof. Right. So it's basically a group of people who are very much interested in how medical education can be better. Yeah. So without further ado, today's topic is really clinical teaching, and how do we roll out effective clinical teaching. So Prof. Zah, the floor is yours, and we are hopeful for discussion at the end, and we allocated 1 hour and maybe plus another 50 minutes or so for Q&A. So we're going to have ample time for exchange of ideas and opinion.
Thank you. Thank you very much, Prof. Tong, for the kind introduction. First and foremost, I must say a disclaimer first that I'm actually not the expert in clinical reasoning. I would say I don't claim to be. I think the expert in clinical reasoning, as far as UKM is concerned, is probably still Prof. Dato' Halina, and I learned from her as well. But there are some things that I feel strongly about with regard to clinical reasoning, the application to bedside teaching. And since I hold a portfolio of bedside teaching or clinical teaching in our JIPP that Prof. Tong mentioned just now, so I thought I should do my part by, at least presenting and sharing for once rather than being in the audience all the time. So time for me to do a little bit of work and share with everyone. So I shall share my screen now. Right. I'll put this on PowerPoint slideshow. Okay. Right. Clinical reasoning in bedside teaching. I feel very strongly about clinical reasoning, as I've mentioned, because I think the logical thinking behind how clinical reasoning should be conducted is very important in our education of particularly our undergraduates, but also our postgraduates as well. And studies have shown that that is very important, crucial for the sake of patient safety. And definition-wise, clinical reasoning is defined as the process by which clinicians collect cues, process the information, come to an understanding of a patient problem or situation, plan and implement interventions, evaluate outcomes, and reflect on and learn from the process. So basically, it is the thought process behind what we do clinically. And the terms clinical reasoning, clinical judgment, problem solving, decision making, critical thinking are all often used as equivalent to each other. So the process of clinical reasoning itself in medical practice starts off with collecting information. In other words, our history taking and physical examination. And then from there, the thought process that goes into the process of making a working diagnosis, and then considering differential diagnosis, and then the immediate management in terms of treatment and monitoring. And then from there, you collect further information from your monitoring and all that, as well as from your investigations. And then you come to the final diagnosis. Then from there, there is further management in terms of treatment, monitoring, and future plan. And then from there also, you do not stop thinking about whether you have done things correctly. You will then reflect and review on what you have done and the outcomes that result from your decisions. And then from there, again, the whole cycle starts again with collecting information. And the importance of clinical reasoning. This is something that we have to emphasize to our students. Effective clinical reasoning have a positive impact on patient outcome. And poor clinical reasoning skills can lead to failure to detect impending patient deterioration and results in failure to rescue. A lot of complications can occur from there. And certainly as doctors, we do not want those sort of things. So because of that, we've got to polish our clinical reasoning, no matter what position we are, from students right up to even consultants. It is something quite sort of like mathematical, logical, that you've got to keep polishing, throughout your career so that it becomes better and better. Top 3 reasons for adverse patient outcomes has been shown to be failure to properly diagnose, failure to institute appropriate treatment, and inappropriate management of complications. And all this can arise from what is called cognitive failure, the failure of clinical reasoning behind the clinical management. Okay, failure to synthesize and act on the clinical information that you get. Okay, so none of us want to be caught in a medico-legal tussle. So now, one model that can be used for teaching clinical reasoning is virtual patients. And for that matter, screen-based simulation as well. Okay, and it has been shown that teaching clinical reasoning using virtual patients is more successful than teaching, say, communication skills or ethical reasoning using virtual patients. So this is the evidence, the odds ratio there you can see very much far to the right compared to this is for communication skills and ethics teaching. Yeah. This is clinical reasoning teaching. Okay. And now there are some key elements in the process of clinical reasoning. First, of course, is data acquisition, just like in the flowchart that I've shown just now. And then problem representation and semantic qualifier as well. They sound like very bombastic terminologies, but basically this is what we do day in and day out in our wards and clinics. Okay, the case summary with key elements as the basis for working differential diagnosis, that's the problem representation. And semantic qualifiers basically are simply discriminating descriptors. For example, sharp versus dull, whether the problem is acute or chronic, whether there is any tenderness or is it a non-tender, mass or whatever, okay, or complaint. Whether the whole problem is of insidious onset or abrupt onset. So you balance between these two in a sort of like a dichotomous kind of way of thinking in order to arrive at your diagnosis or decision. And generation of differential diagnosis and working on the hypothesis is comparing and contrasting possible differential diagnosis based on the information or data that you've gathered from the patient in terms of history and physical examination, as well as your background knowledge and experience. Okay, so you match these two and see where you land. Okay, now illness script generation, again, you know, illness script sounds like foreign to us clinicians, but basically what it means is an organized mental summary of knowledge of a disease. So what you know about the knowledge. For rare diseases, it can be just one flash cut. That's all you know. Okay, but for common problems, okay, you might know a few 100 pages on the disease or something like that. Okay, this includes predisposing conditions to the disease, pathophysiological insults, and clinical consequences or complications of the disease. Okay, and this is what you would compare with the data that you got from the patient and then see where you land. Diagnosis selection through dual processing. Now, what it means here by the dual processing is two types of reasoning. Okay, analytical reasoning, meaning pattern recognition. The patient presents with a certain pattern, and then you know various diseases with their various patterns, okay, and see where they match. Okay, this is a bit of a slow and deliberate conscious process, okay, as opposed to intuitive reasoning. Okay, again, you are actually mapping the illness script that has been generated from the patient data, okay, but with your existing what do you call that, experience, okay, from your past. And because it is your existing experience already ingrained in your mind, the intuitive reasoning happens faster. Okay, like an example that is given is like, for example, if you see a coffee mug in a cafe, what you expect is there is coffee in it and there is and it is hot. Okay, so that is intuitive. You know, you come to the conclusion very fast. All right, whereas analytical reasoning takes a bit more time for you to map one illness script with another. So this is what I mentioned just now as a kind of like dichotomous semantics, okay? Semantic qualifiers. If you have a patient with chest pain, you will ask yourself whether this is acute or chronic, or you verify with the patient whether it is a single episode or has it been there previously. If it is chronic, is it continuous or is it intermittent with an isolated incident in the past? If it is intermittent, is it exertional, non-exertional? If it's exertional, then finally you will end up with a diagnosis of angina. So that's how your thought process is. So this is clinical reasoning. And this is the illness script in terms of the pre-existing knowledge that you may already have. Okay, what are the predisposing conditions for the illness? What are the pathophysiological insults? Or what are the clinical consequences? And you map that against the illness script of the patient. And these are the key elements, again, of the clinical diagnostic reasoning process. You have the patient story from which you acquire data, okay? Then you have problem presentation, generation of hypothesis, and you search for and select what illness script would match that, and then you arrive at the diagnosis. And in the background is your knowledge, the context of the patient, and you know, the situation where the patient is in, whether it's acute, chronic, and so on, emergency or whatever, and your experience that you plug from in order to arrive at to help you make the diagnosis. So this is the stepwise approach. Step 1, the problem list, identify all abnormalities in the case and process it into uniformly descriptive medical terminology. Step 2 is to synthesize, meaning summarize the identifying key features in terms of epidemiology. For example, you would rather think about something common rather than something rare, okay? Because it is more likely to be a common problem rather than a rare problem. the temporal pattern in terms of acuteness or the chronicity of the problem, or is it episodic, and whether it fits into any kind of syndrome. And step 3 is prioritizing the differential diagnosis, matching the patient's illness script to the classic disease illness scripts that you have already in your head. Okay, so the better the fit, the higher the likelihood of that being the correct diagnosis. So this is what is called SOAP in some medical schools. Yeah, subjective, objective, assessment, and plan, SOAP. Okay, this is the SOAP approach. Okay, subjective in the sense that you collect the information from the patient. Objective, the subjective part is the history. The objective part is the physical examination and the investigations. The assessment consists of your formulation of diagnosis, and then from there you plan your treatment, medication, and all that. So the whole process underlying that is the clinical reasoning. And now, how do you approach teaching clinical reasoning with your students? First of all, you've got to sort of like learn the language and theory of diagnostic clinical reasoning, which is what we're doing now, just to be familiar with it. To be honest with you, I think all of us apply it in our everyday teaching of students, but sometimes we're not aware that it has got a name, clinical reasoning. Okay, it's the logic behind the clinical thinking process. And we need to understand the process of reasoning as a prelude to workplace experience. So even if you're in, say, preclinical, you teach PBL, for example, problem-based learning, all right? There is also clinical reasoning behind it. The process is there. And it would be good if the students are brought through that process of reasoning as a prelude, as a predecessor to the exposure to the workplace, where again they would apply the same clinical reasoning, okay, but in the real case scenario. And you need to experience and gain understanding of clinical reasoning in action through workplace practice and feedback, and reflect upon your reasoning during and after practice to further understand, criticize, and develop reasoning abilities. Okay, so in the workplace, what happens is once you have decided on the diagnosis, you have decided on the treatment, investigation and treatment, you apply all this, you implement, and then there would certainly, of course, there will be an outcome to what you have implemented. Okay, and from there, actually, the outcome will then teach you as a kind of feedback whether your reasoning has been sound or not. If your reasoning has been sound, the outcome will not be far from what you have anticipated in the forward process. Okay, and reflecting upon this will then result in your learning or gaining experience for future encounters with similar cases. So the whole process of the clinical reasoning will then repeat itself when you find another similar case. So you've got to be aware that the whole process is what we call clinical reasoning, and what is important in order to polish your skills in clinical reasoning is to practice, practice, and practice, either in a simulation-based kind of situation or in the actual workplace scenario. So how do you apply this to bedside teaching? I always tell my students that they've got to have a strong knowledge foundation. If they don't have it yet, if they didn't do all that well in their preclinical years, then they would have to revise more intensively during their clinical years in order to recall back what they have learned. Okay, so that knowledge foundation is very important. And active participation in what work is also important in order to enrich their experience in seeing real life cases where the outcome is there for them to reflect on and see whether you know, the clinical reasoning that the whole team of the whole clinical team has applied and implemented is correct or not. And how to apply? Always ask. I tell my students that they always have to ask the why, not just blindly adhere to clinical protocol of management. Okay, why is this done this way? Why is this done that way? So that the clinical reasoning becomes sound and logical. Okay, and logical thinking and common sense are two very important things that have to be ingrained into clinical reasoning for it to be sound. And practice is of utmost importance, whether they practice on hypothetical cases in a simulation scenario, for example, or in study group discussions. They can even have paper cases. Or nowadays, you have screen-based simulation like DSR clinician and lots of other screen-based simulation that can help them. So this is the clinical reasoning process or cycle. Okay. You start off with considering the patient situation and then collect cues or information, process the information, identify problems or issues, establish goals in the patient treatment, what you want to achieve when you treat your patient, take action, meaning implement your plans, and then evaluate the outcomes. Then last but not least, reflect on the process, and then it will result in new learning and new experience that you will be able to use in your next similar case. So this is an example, okay, or elaboration on what the clinical reasoning cycle is about. When you consider the patient situation, it means that you describe or list the facts, context, or objects or people, okay, the background of the patient, for example. And then collect cues and information. You review the current information, gather new information, and recall whatever knowledge you already have in your experience. And then you process this information, match them, okay, and see where you arrive in terms of identifying the problems or issues and arriving at your diagnosis, okay? So once you synthesize your diagnosis and then you describe what you want to happen, a desired outcome and a time frame for that to happen. For example, say it's a case of fetal growth restriction, okay? And here you need to, once you've clinched your diagnosis of fetal growth restriction, you establish the goals of your treatment or management of the patient, what you want to achieve. For example, you want to, definitely you want to prevent stillbirth. All right, how do you prevent stillbirth? In terms of timing of the delivery, for example, monitoring of the fetus in utero as well, and then timing of the delivery and how do you deliver? Okay, these are probably the three key things in terms of the goals that you want to achieve. All right, and then you take action. You monitor, okay, according to what you have planned. And also you deliver the baby according to the timelines that you have planned and the way that you have planned, whether it's abdominal or vaginal, okay? And then you evaluate your outcomes. Did it reach the outcome that you anticipated? Okay, did you get a, you know, bouncy, beautiful, healthy baby? Did you get that? Or did it become an adverse outcome? If it's adverse, why? This is where you would contemplate what the outcome has now become and reflect on it, and new learning occurs. Okay, and then you go back to this position when you encounter the next case of fetal growth restriction. So that's the clinical reasoning cycle. Now, clinical reasoning skills would be different at different levels of expertise. Okay, for example, the novice residents clinical reasoning may not be as comprehensive as an expert resident's clinical reasoning. And as we grow more mature, I wouldn't say older, grow more mature in our clinical exposure, hopefully we'll be able to have better clinical reasoning compared to when we first started out as a medical student. And teaching clinical reasoning to medical students need not actually be only restricted to, say, PBL or bedside teaching. Studies have shown that it can also be taught in a paper form. Okay. For example, this one, teaching clinical reasoning in times of the pandemic. People have used paper cases. All right. Like if the diagnosis is myocardial infarction, okay, what are the information that you would expect in the history, okay, to be present, to not be present, compared to another diagnosis like pulmonary embolism, which is a differential diagnosis of the myocardial infarction diagnosis, okay, that sort of thing. So, well, although this is called paper case, I'm sure it can also be done online, okay, using the online tools that we have, okay. So there is no excuse for not teaching clinical reasoning simply because you do not have a real patient. And as I've mentioned, the XR clinician is one example of a screen-based simulator that can be used to teach clinical reasoning. This is how the contents would look like. Okay, you would have a kind of like a virtual patient to handle right through until your management, treatment, and all that. So, in conclusion, clinical reasoning is the cognitive operations allowing clinicians to observe, collect, and analyze information that ultimately leads to action, meaning diagnosis and treatment of the patient. If I can put this in different words, clinical reasoning is the thought process that goes on behind the scenes using prior knowledge and experience that the clinician has gathered previously. So two vital prerequisites to produce good clinical reasoning are a strong foundation of knowledge and experience to pluck from and an efficient information gathering skills. You have to be slick, skillful in gathering history and eliciting physical examination, as well as ordering the correct investigation. And this is what the basis, the basic skills that we teach our students. Effective clinical reasoning skills have a positive impact on patient outcomes, and a majority of adverse events arise from failure to analyze clinical information, which is why good clinical reasoning skills are vital for patient safety. I think that's about it. Rather short presentation from me. I'll stop sharing now in case you've got any questions.
Yeah, thank you, Prof. Thank you for creating space for discussion. I think this is an interesting topic. We always say medical students don't think common sense commonly. That's we all struggle in trying to get them to think in the more analytical way. And so that's really a challenge for clinical teachers. So that's why this platform is created, see how we can advance this in a way, sharing experience. There's an early question coming in from Boon Singh. Thank you, Boon Singh. I'll just call out names, as I guess that will be all right for everybody. So is it possible, how do we manage or prevent passing implicit bias during teaching? So if I get the question correctly, Boon Singh, if you want to clarify if I got it wrong, our own intuitive thinking, it itself might create some bias from our side, and we may pass on with this kind of thinking to the student. So how do we manage that in our during teaching, of clinical reasoning?
Well, before that, I think Prof. Tong, I think we encourage people to unmute and show their faces as well if they want to ask, right?
Yes,
so
correct.
That will make it more interactive, and probably we can progress with the questions faster, kan? So okay, implicit bias, that's why I think it also sometimes it depends also on where you come from, which clinical setting. If you come from a clinical setting from a developing developing country, for example, or if you come from a developed country, your implicit bias will be there. You know, how your clinical reasoning works, and also the kind of cases that you're exposed to. Like if I were in UK or Australia, maybe I would think about cystic fibrosis much more than I think about dengue, for example, you know, in certain situations. So the kind of spectrum of common cases, because epidemiology is different in different places, and the protocol of management is also different in different places depending on the facilities that are available. So I think that is acceptable, but at the end of the day, it depends on your target in terms of you're educating that particular candidate for which kind of setting, which I think by and large, you are at an advantage if you train in the place where you finally aim to work in, right? Yeah, which is why, you know, even housemen, for example, if they come from overseas medical schools, when they arrive here, they struggle a little bit in terms of making sense of what they see in our clinical scenario. Because, you know, they will be thinking of all those diagnoses that they see in other places, like those from Egypt, maybe they think more of schistosomiasis, you know, compared to somebody who trained in Malaysia, we think more about malaria, dengue, or whatever, all the common conditions that we see here. I hope that answers your question, Boon Seng.
Boon Seng?
It's sort of like I asked sort of like a little bit of provocative questions, because it's to really to spark the discussions, because taking students through clinical reasoning, I can see that they see the sessions as sort of like a PBQ kind of paper based. They don't think about around the patients, but they just vomit out sort of like what they memorize in their mind. So and also with a lots of assumptions back there that if they give disproportionate attention to some details and make assumptions around that. So I believe this is a common problem faced by most of the clinical teachers. So it's really to put up so that we can discuss. Yeah. Sorry, my camera, my situation doesn't allow me to turn on the camera.
No worry.
Right. Yeah, that's okay. Yeah, thank you, Boon Seng. Yes, I think you brought up a very pertinent point, which I find among our students as well. And they seem to be detached from their patients. That's what I often find, you know, they take the history and all that, but they don't really, well, the Malay word is menghayati, I think, you know, they don't really feel, you know, for their patient. Which is why I often tell them that they are in the wards and the clinics as apprentices. They sometimes forget that their way of learning, this is particularly undergraduates, not so much with the postgraduates because they're already working and they are already embroiled in the, you know, clinical management and all that. So they can feel for the patient better. But the undergraduates, they very often are detached from the patients. So I tell them that they should be involved in the, you know, day-to-day management in the ward as well, as much as they are allowed to. For example, if they should find out about their patient's level of health education, for example, you know, and then what they can do is they can go back, read about it, and share their knowledge with the patients. Okay, in terms of investigation, you know, if the patients have had some investigations sent to the labs, they can help to, you know, trace back the results and all that. That will make them be more involved in the patient management. And I think that way they will be able to reason much better as well, because they are within the clinical setting rather than looking at the clinical setting from a distance.
Yeah, I have the slight, I mean, there's also other experience I had with my student, because we also see patients referred to us with different setting, and therefore differential diagnosis is very different. That's where, Professor, you were talking about hypothetical analytical method of thinking, where they have initial information I derive from some hypothesis of differential diagnosis and work through collecting further information. So there's one strategy that's been used. I'm a family physician, so general practice perspective, Prof. John Mota has actually come up with some kind of strategy, I think very common and very practical. That is the think about common disease at that particular setting commonly first. So that develops some illness script. So it goes back to the same thing as you've just described, knowing the epidemiology of the disease in a local setting. Even in local setting, in primary care setting, the differential diagnosis is different from A&E setting, from ONG setting and whatnot. So therefore, cases referred, for example, in internal medicine, they might think differently because the epidemiology of cases you see there is different from primary care. So the common diseases in different settings is different. So the priority of diagnosis and illness script can be quite different. So if they collect initial information and then they map it with the common diseases and work it out from hypothetical methods. So they think that way might be easier to teach, because I totally agree. When the first year 3, for example, a very early clerkship, they plug and describe the disease symptom in very structured and formatted, what is the onset, duration, precipitating factor, relieving factor in a very orderly manner. And there's no story behind it. Basically filling in so it doesn't form a very good illness script. So we want them to describe in a way more naturally how symptoms evolve, and that create an illness script that we can map. And that can map to the common disease. And then that's a teaching goals. And then, of course, we want to cover up the dangerous disease because we don't want to miss things. So we'll ask ourselves, what are the common diseases that we usually miss, or usually people miss? And there's another one is, what is dangerous disease? So common disease usually miss, and dangerous disease. So it kind of gives us some safety margin to deal with. Now, this is often talked about diagnosis, but of course, it goes beyond when talk about investigation and treatment and reasoning of those. So that's why I get a little bit about experience of how to teach this clinical reasoning to a very early clerkship, which is very difficult actually. So
sorry.
Sure.
Can I say something?
Sure. You're most welcome.
I'm new, but formerly from UKM.
Hi, Prof.
Hi. I agree with Prof.
Long time no see.
Yeah, that the young students, the year 3 students, when they come in, they are so concentrated on doing the Socrates thing, and they will take every little symptom to its zenith, If a patient with URTI, they will ask all about the cough, the headache, everything that they forget. They look at all the trees, they forget the forest. Okay. The other thing that I read about clinical reasoning is you have to share with students. I mean, I'm talking about bedside teaching, either in the clinics or on the ward. You have to share with students your clinical reasoning behind it. Because you will say, okay, I'm thinking of this. But if you didn't share your reasoning behind it, they still won't know. So this is where I think you have to tell them, I'm thinking of this first because this is the most common. This patient's symptoms or whatever fits in with this. But he also has these other things. You have to consider this, that kind of things. That's what I gather. But I agree that for that to occur, they must have a good knowledge base. Without a good knowledge base, they can't go anywhere.
Yeah, very good point, Prof. Yeah, I agree with you. I think just now, Boon Sing had another question or something. He wrote, he raised
some provocative one about how do you prevent your bias, your personal bias from getting in. That is provocative, you have to answer. It's a bit more difficult to answer.
Yeah, the bias will always be there, depending on your prior experience, particularly. Yeah.
There are one author looking at about how doctors think. And one of the strategies that author promoted is actually ask the patient in particular, what do they think about our decision in some way? It acts as a way how we can step backwards and ask our opinion to be appraised by another person so that our opinion can be challenged. And when people challenge our opinion, we will think a little bit more to erase our bias in some way, to minimize that. That's one of the...
Yes. And you always have got to have that humility to review your decisions. Whether it's diagnosis or treatment, you know, and not just stick to your guns and not want to let go, you know. Yeah, that's very important. I think there's somebody raised her hand, Siti Norashikin, Prof. Tong.
Because our pictures are pink, so I can't see you.
Oh, okay. Siti Norashikin there.
Okay, Siti Norashikin, yes, please do.
Hello, Siti Norashikin. Would you like to pose your question?
Is there a mic?
She was trying to speak just now. I think maybe the transmission is not very good. Bunsing again.
So probably while Ashikin is getting ready for questions, sort of like the discussion sort of like carry on. I'm from a medicine background, so sort of like resonating with Prof. Tong that students tend to be very meticulous in the way that they go from step A to step B, and probably in my reflections, could it be the way that we assess them in the final or in the exam, that you must be meticulous, you cannot miss this point and that point, that's why they become extra cautious and very careful to not miss a lot of things, so they ask everything. So this is probably, could it be related to, could it the fault be on us that we assess them in the assessment is not aligned with the need of clinical teachings, probably?
Hi, Prof. Can you hear me now?
Yes.
Okay. Sorry. Maybe you want to ask. I want to answer Prof. Bunseng's question first.
Now, Bunseng, can you repeat the gist of your question?
Oh, so sorry. It's really meant for discussion. So I'm just reflecting on Prof. Tong's just now saying that.
Okay. Right.
Yeah. It's not really a question, so that yeah.
Okay, sorry, my microphone was not working very well, so I couldn't hear very well also just now what Prof. Bunseng was saying. So thank you, Prof. Zaleha, for talking about this issue. So I'm actually a student in medical education. So I am actually doing a PhD on clinical reasoning itself. So it is very timing that you have this lecture, and I'm here to listen to your lecture. So Prof, if I may ask, what is your take on the clinical reasoning in preclinical students? So I know that you have already discussed about PBL, but is there any other ways that preclinical lecturers can sort of implement or can make sure that students in the preclinical years are being exposed earlier to clinical reasoning?
Right, good question. Actually, there are various ways. PBL is only one of them. Obviously, for you to teach students on clinical reasoning, there has to be some sort of clinical material. One of the methods that is used, I think, in most medical schools now is the CSL, the clinical skills learning sessions that we have with them, taken by the clinicians themselves. I think that is one situation where they can be exposed to learning through clinical reasoning. Prof. Tong, do you have anything to add?
Yes, I was just thinking about unit script. I think unit script is one of the hallmark of clinical reasoning. And I wonder this illness script, when do we develop it and how can we help students develop it? Would it only during clinical years or they can start developing it during their preclinical years? As you had mentioned just now, the pathophysiology, this is how it leads on to clinical sign symptoms. So if the more unit script they have, that will form the foundation, Prof. I think, or maybe she can have other things to add on. I guess I didn't study clinical reasoning. I'm learning from everybody, so things are bits and pieces for me. So I thought might be one of the way to develop the good illness script. So our students, when it comes to clinical years, I will ask them, do you know about the typical presentation and the pathophysiology behind that? I suppose that has need to be built up when they come to clinical years. Ready hopefully they are ready, like in a way. We are all very greedy. We aren't good students, but I suppose that is happening in preclinical years. I think one another way.
Yeah, I think that is one way for them to have a strong, knowledge background of the diseases that they learn in their preclinical years. That's very important. We really appreciate that as clinicians when they come to us. Norman has turned on his video.
Just want to add something because just reminded me. Dengar?
Yes.
Okay. Actually, yesterday I given a talk to the online conference between UNIMAS and Russia talking about integrated curriculum. In terms of clinical reasoning, especially in preclinical, it all, depends on the type of how integrated the curriculum is. So if the curriculum have a very nicely done vertical integration where you involve, just like what we did for CSL, where all the preclinical stuff, history taking, physical examination are done by the clinicians, and then maybe sometimes during few years ago where we limited to the preclinical who have medical background to lead these groups. So with that is because in order to do clinical reasoning, you need to have done an experience in clinical setting. How do you, just like what Bun said, that what is your thinking, what is what Prof. Kwa said, what is your thinking, your mind thinking about that particular problem, whereas because the preclinical students doesn't have any I would say extensive exposure to clinical per se, like clinical students, but hopefully, but at the end of the day, I would say that my personal view will be how the integration of curriculum be done, that it will help definitely in terms of the clinical reasoning among the preclinical students, I believe. Yeah.
Actually, Boon Singh has actually raised two issues that we have not discussed. We can discuss. One is the I noticed Boon Singh the same experience we had when we go through OSCE, for example. They come with a list of checklists, and then we require students to fulfill the checklist. And sometimes a very good student doesn't need to go through the checklist to hinge the diagnosis because of the way how stories are being reviewed. So they can be very quick and smart in terms of story building, and that matches the illness script very well. And the common disease come out just like that. It is a challenge. So I don't have a good answer for you. I'm just putting up similar experience. How do we bring the two together? And you raised a similar question in your chat, and I think Dr. Noman has addressed some of that. How is it too hawkish to teach clinical reasoning in preclinical students? So Noman was talking about how integrated the curriculum be. And
yeah, I can imagine it's not easy to teach clinical reasoning at the preclinical level because they are not seeing the outcomes of whatever diagnosis they make or plan of treatment that they have outlined for the patient. Perhaps this is where I suppose one way is for the facilitator to guide them through, what the outcome may be, or give them a probable outcome. It may be based on true cases, true clinical cases that are fielded to them and used in their learning. But the immersiveness will not be there like what it is in the clinical years, Yeah, so because the involvement is not there. So, but I think what is important in the preclinical years is very, very, very importantly to strengthen their knowledge foundation. As you said, the illness script, Prof. Tong, that is the main thing that they must develop during the preclinical years. Maybe a little bit of rudimentary clinical reasoning is acceptable, but not a lot until they come to the clinical years. I think Prof. Kwa wants to say something.
I want to say that the problem with preclinical learning that I found from my experience is like SEM 2 and SEM 3, they only know some things. They only know, say, cardiovascular and respiratory. So if you have an epigastric pain or chest pain, and some things go into the abdominal, they won't know. If you only know chest, respi, they won't know how to bring in the other things. So they don't see the full picture. But that's why clinical students, we think ought to see the full picture. But unfortunately, they have so many things and they don't know which one to pluck. And some of them love to pluck the cherries right at the end. I always tell them, pluck the ones that is nearer to you. That means common things common. They will bring cystic fibrosis and what have you. I don't know whether that's your experience.
Yeah, true. Producing students with a very strong knowledge base in the preclinical years, I think is one of the challenges that we face. Nothing like having a student with a very good, knowledge foundation, and it's like so blissful, so easy to teach. In the clinical years, if they are, that kind of student, the clinical reasoning will almost like fall into place, usually.
Yeah, true, Prof. When you have a very good student, then it's easier, easy life.
And the logical thinking behind it.
Yeah, Prof, can I just add? So I'm actually teaching physiology. So I think in our center, what we did, we teach them everything according to the illness script. But I think it depends on how the teachers and also the students, how they want to make the illness script out of the knowledge that we have given them. I know it is very difficult. And I think that teachers also need to have this sort of ability on how to teach students on making their own illness script, because everyone has their own interpretation of their own illness script. So I think it is also quite pertinent for the teachers to actually know how to teach the students how to make their own illness script.
And I think one very important thing actually where the students are concerned is their depth of learning. You will find that those students who learn a bit more in depth about, pathological conditions, even about physiology, the human physiology, they will be able to reason better because they know the why behind it, and also because their illness script is so much more, easily reachable to them when they can rationalize things better, okay? And because of that, they can remember better. Those who do not rationalize what they learn in terms of the pathophysiology, in terms of whatever, even like drug side effects or whatever, if they do not rationalize it and know the why behind the knowledge behind, all the things that they learn, they just memorize just like that blindly, you'll find that they don't reason as well as those who learn deeply and know the why behind things. Tim Boon Sing has got another comment to make.
So I just want to extend the discussions of Prof. Kwa and also sort of like chipping in the chat with Ashikin, in the sense that probably if a PhD work to do, probably we may want to look at what are the foundation of good clinical reasoning, like what builds up, what supports good clinical reasoning in clinical years, so that we sort of like build those foundations instead of the clinical reasoning proper in the preclinical years, so that they could the functional knowledge would be useful. An example raised by Prof could be like, if the patients have chest pain, so we have to think of cardiovascular system, respiratory system, and abdominal system. Probably this is suffice enough for preclinical years, and then when they are in clinical years, then have to add on. So if it's a respiratory system problem, then what are the conditions in the respiratory system that causes chest pain? Something like that. So it's really my on the spot reflections here.
Thank you for that comment. Yeah.
Thank you.
It'd be great that in some way don't scare the student all the way.
Hafizul has turned on his video. Wonder whether he wants to say something.
Hi, Hafizul here. I think what we've done so far in our medical school is actually quite great, whereby we try to integrate clinical reasoning really early, even in first year to our preclinical years. But the thing is, as people have mentioned, as you have mentioned, they don't sort of relate the basic science to the disease itself. And what I notice, what I normally tell them to do is, do not, right after the PBL session, do not chuck out your PBL after you finish your year 2, because you're going to clinical years, because those topics that were presented to you in PBLs during that 2 years of preclinicals are really essential, and you need to use those basic sciences to bring you up, in clinical years. So what they tend to do is, okay, now I finish preclinical years, I stop it there. Now I'm a clinical sort of student. I make a new fresh start. So they will start to struggle. So if we ask them, okay, so what's the underlying sort of like basic science of jaundice, for example, they will scratch their head, although they have actually learned it before. Yeah,
that's very true. Thanks, Hafizul. I think that goes to emphasize also on the depth of learning, that they are willing to immerse themselves in the preclinical years. The deeper they learn, the better clinical reasoning they would be able to conduct. I think Prof. Jamia has raised her hand.
Hi, I'm not so sure whether you can hear me because I'm outside.
Oh yes, very clear.
Oh, thank you very much. No, I think clinical reasoning is very important to teach, but the thing is, we also must ensure the academic staff also can teach clinical reasoning. Sometimes we assume the academic staff, they know how to teach. It's not necessarily they know how to teach step by step, as what you have presented just now, in a very stepwise manner, but in real life, they have to teach the student. That's what you said. I agree. Student can be novice learner, but with experiential learning, they can learn better, and the academic staff needs to guide them. So when we talk about preclinical years, clinical reasoning is very important to teach. But of course, like what you say, there is not enough clinical experience. That's where curriculum has early clinical exposure. But you can still teach the basic of clinical reasoning by asking, for example, like anatomy, physiology, how to connect. For example, they learn about the voice, and if there is vagus nerve being cut, what happened? So in some way, clinical reasoning is to understand the pathophysiology that they learn in preclinical years into clinical is how it presents, to connect it. But I think sometimes not many academic staff ask that. For example, if you have a patient who has hypertension before pregnancy, 140, 90 also medication in the first trimester, suddenly when she takes medication and she feels dizzy and hypotension, then you need to ask the student, why do you think so that she had hypertension before, but now with the medication, even without the medication, her blood pressure is low. And if you take the medication, it's lower still. Then they need to think in terms of the pathophysiology of pregnancy, how the reduction in the systemic system, placenta circulation, openness of anastomosis, then they would understand. But the thing is, they wouldn't know the process. We are the one who guide them. So with more experience, with more patients they see, of course, they will get better and better. It'll never stop until now. Even us in this, where you say mature, well, we are senior clinician. There's some situation like COVID, we still don't understand. So we still need to relate why certain things happen. It's the same thing. So I think it's important for the academic staff to be taught. I mean, not to be taught, to know how to guide the students in terms of clinical reasoning. Sometimes they know, but they don't know how to guide them. So the student depends on us, of course. So we are the one who teach them. So the more you teach them how to do, and later on you can watch them doing it independently, but they still need to be corrected as time goes by, because they will be not having enough experiential learning in all the other cases. So this is where I think that's important. I think clinical reasoning is very important in preclinical as well as clinical, but the preclinical is the basic. But the most important part, I think, is when the students are in year 3, that's where a lot of emphasis should be given in clinical reasoning. So by the time they progress to year 4, 5, and they become household medical officer, if they get very sound foundation, good clinical reasoning techniques, they get better and better and more independent, I think. That's my take on it.
Maybe it would be a good idea to give this clinical reasoning lecture to students who need to conduct the clinical reasoning themselves. I don't think we've ever taught them.
Yes, I do it in UITM because I think it's important. So for this year, we gave a lecture on clinical reasoning, how they can do it, because they need to know how to do it. But again, it also, a lecture is a lecture. They need to practice it.
Yes.
So when they practice clinical reasoning, we are here to guide them. So we shouldn't sort of be biased if they don't get it right. So we should teach them. So that's where it is. They get better and better.
Yeah. At least they know the cycle. They know what the steps, the terminologies, you know, what is illness script and things like that. And we tell them where is the place of clinical reasoning within, you know, what they always do every day.
But I think, you know, Prof. Zaleha, I think patience is very important. Not patient, patience.
Yes.
Because when you teach clinical reasoning, 1 hour word round is not enough. 2 hour word round, sometimes 1 hour is just correcting the presentation, how they approach it. But clinical reasoning is another issue. So it takes longer to teach them. So it's not prescribed time. Sometimes it can be 2 hours to teach them how to connect within that patient to the basic pathophysiology and the process. So it takes time. So the academic staff has to be a little bit more patient to allocate more time. So sometimes you see what around 1 hour, you know, on the timetable, but it's never enough.
In fact, it's probably more restful and comfortable to teach it online, where everybody's seated comfortably, you know?
Yeah, online you can do, but it's case-based discussion. So that's slightly different. You can't check the signs.
Yes.
Tell them,
That's the only limitation. Yes, that's right. Yeah. I think Shikin has got her hand up again.
Yes, thank you, Prof. Jamie. I agree wholeheartedly with what Prof. Jamie was saying. So I think it's also important for the teachers to know how to teach clinical reasoning. But Prof. Zaleha, can I just ask you, what is your take? Because I've read somewhere that we know that clinical teaching is something that we can teach the student, but some of the academic staff said that clinical reasoning is something that cannot be taught because it is something innate that is coming from the students. So what is your take on this, Prof?
Okay, I think actually there are two aspects to it. Okay, I think intrinsically, if they are smart students, naturally the clinical reasoning will be easier because it is logical thinking and common sense. Lots of that. You know, the component of logical thinking, rationalization, and you know, common sense is very strong in you know, making doing clinical reasoning. So if they are smart students, definitely it will be an easier journey. But I do believe that it can be taught and polished. You know, the more you are exposed to the process of clinical thinking, clinical reasoning, because I think from what I've read that I've shared with all of you today, there is a process to it or a flow to it, you know, and you can keep repeating the cycle and becoming better and better at doing it, you know, as time goes on. And certainly the more you're exposed to the clinical setting, the more cases you see and all that, the better your clinical reasoning will be, because your experience gets better and hopefully your knowledge also gets better with a lot more reading.
Yeah. Would say you have something to add on?
Yeah, it's really about extending Shikin's discussions. It's like it's sort of like I see clinical reasoning is sort of like a kind of metacognition, thinking about thinking, and kind of, if you say something it is innate, then why we teach at all? Because we teach so that there's learning ongoing, or I don't like to think that we teach you, kita bagi something to students. Probably it's like we facilitate the learning in the sense that so that learnings happen and students grow. So I kind of say reluctantly would disagree that if something is innate. Yes, the pattern of thinking is could be quite consistent, but there is a chances to develop it. Yeah, sort of.
Yes, good grow mindset, Boon Seng, I think I would say. Yeah, I do very much agree with you. I believe strongly that it can be taught, it can be learned.
Yeah. I have a few points. We have about quite a bit of minutes, 5, but I just want to summarize it and see how it goes, because the discussion goes quite well, and I'm facilitating this and I'm learning a lot, and all of us actually, to a stage, we develop our own clinical reasoning, knowing or not knowing it, as Prof. Zah has put it. It's just making it very explicit and with terms and some jargon, so that it actually points, so that you can communicate easier what we meant by illness script and hypothetical generation goal and a cycle of reflection. All those are pretty generic, I would say, but in making a name there, so that it makes our thinking more explicit and easily shown to students, so that the mirror is, of course, learning have taken a various stages. Some, I wouldn't say smarter or not smarter, but some are more analytical students. They develop their own innately, correctly. But there are many more also would like to help to, in a way, facilitate them, as what we're saying, facilitate them through the learning process. Making them clear about explicit our thinking will put them in a more the perspective. They can orientate their thinking a lot more easier, so they can gel the jigsaw puzzle better. So I take it here that illness script with pathophysiology and link it to clinical presentation as we discussed, and with a deep reflection of how things evolve and why, the reason behind all the clinical presentation and all the clinical decision that will be helpful in terms of illness script building. And it can start, I guess we all could have agreed that it can start in various stages, but foundation, how much to put in, well, that really look at curriculum design and how it can build slowly. Of course, Prof. Jamal was saying that we need to be patient and teach, you know, cycle really need a lot of cycles. It's not one-off thing, and we need to be patient. Yeah, indeed. So I think that some of our discussion in some way. If there are some other things that we want to add on before we end the session, we have about 12 minutes to 5:15 to 4. So you're most welcome. So I guess this is a really fruitful discussion. We take home something.
It's triggered me, Prof. Tong, to think that perhaps we should actually really seriously have a lecture on clinical reasoning for the students at some point, maybe at the CSL, or at the, you know, when they first enter third year, either one.
Yeah, agreed. I agree. They need to be shown clearly exactly how the whole thing, the games are played.
Yes.
How the games are played. Yeah.
Yeah.
Yeah. Right. Those other comment, I think great to have. I think behind the scene, I must say, Zaki and also Azrul is there, pinning here, there, and there for us. Our pictures are up, and also organizing the Zoom meeting and also producing the poster and circulating the information around. I think Prof also circulated information around for many. I thank all those who participated in making this session a lot more interactive. That's great opportunity. We really hope to see how this thing can evolve and whether future will that be an inter-university thingy. So I just think
that would be good. Yeah.
Yeah. All right. So with that, I thank Prof. Zahar again for bringing back, summarizing the whole clinical reasoning is a huge thing, but in a succinct manner, and we can all discuss within it and how we can move within our local context. And lastly, and Selamat Hari Raya, and we are heading for our major holiday break.
Yeah. Thank you, Prof. And
be safe.
Everybody.
Selamat Hari
Selamat
Raya,
Hari Raya, everyone.
Travel
Maaf
safe.
Zahid dan Martin.
Thank you.
Be safe.
You can send us your virtual goodies. That's the best
Have a
thing
nice
about
weekend all.
virtual.
Bye.
Bye.